So the purpose of this talk, and so this is designed to last about 25 minutes. So I hope to have you all away by 1:30. And the aim is really just to give you an update on the National Early Inflammatory Arthritis Audit, which has been recommissioned. The headlines are to talk a little bit about why we're doing it, although I hope everyone is signed up to why we do audit, what we're planning to do, how we're going to do it, and when it starts. And I'm also going to touch on the best practice tariff, which is linked to the audit. And I'll explain about that as we go through and at the end, although that won't take effect as soon as the audit goes live, because that's a little way off. So the why, so national audit, I think we all sign up that we need to do audit. We need to look at how we deliver care and whether we're meeting the standards that we would expect. One of the challenges with doing audit, though, is what your benchmark is. And the challenge of local audit is you can say, well, we're getting close to the standards, but how do we do compared to our peers and compared to other hospitals? And national audit has had some fantastic success stories. So the National Joint Register and the National Stroke Audit Programme are two examples where not only has the audit been enormous success in terms of collecting the data, but actually also over years driven up standards and raised the benchmark for what care needs to be delivered. And one of the things about national audit is this ability to raise awareness and raise the profile of our specialty. And I know that what we're talking about here is an early inflammatory arthritis audit. So this is an audit very clearly around the RA care we deliver as rheumatologists. But actually, if we get rheumatology as a specialty higher up on trust radars, and in this case, if it's a national audit, it gets recognised by HQIP, by the CQC when they inspect a hospital and they start to say, well, this is important. Hospitals recognise us more as a specialty. And if we can get more resource into our departments for the purpose of this audit, I very much hope that the benefits of this will spill over across all of the disease areas we look after, not just rheumatoid arthritis. So what do we do? Well, of course, this isn't the first early inflammatory arthritis audit. The HQIP commissioned an early inflammatory arthritis audit between 2014 and 2016 already, which is currently not running, but we collected data, and it was a challenging audit, and I think challenging learning about how we collect data in an outpatient setting. Remember, the other two national audits I mentioned are both inpatient audits, and there's definitely some challenges quite unique to what we were doing, and also longitudinal data collection. But even across the time span of the audit, we saw changes. We saw the time it took to get people onto DMARDs going from, well, actually, the number of people who met that 6-week deadline was 53% in the first year and went up to 68% in the second year. But probably more importantly, we saw people using the audit as a lever for change to increase resource allocation. So, for example, hospitals, units getting increase in staffing or more expansion of VIA clinics as a result of going to their chief exec and saying, this is our audit data, these are our audit data, this is how we're doing. But of course, it also wasn't all entirely good news. I think we had to be quite sanguine about when we looked at how many of our patients were referred within the nice target of 3 days from primary care, being at 20% nationally, or how many people do we see within 3 weeks of referral, being at just over a third nationally. And across the audit standards, I think we recognise there's enormous scope for improvement. And I have to be honest, I think some of the scope for improvement may be in how we collect the data and data quality. So that was a challenge in the last audit, and I hope we've learned from that. So this is what we've got planned. We got the HQIP award through the BSR last year. Jo Ledingham is the lead, and under her guidance, we will start collecting data on new early inflammatory arthritis cases from April this year, so the beginning of April 2018. We have a new online platform, and one of the major learnings, I think, from the last audit was about the accessibility of the online platform. So that, I'll show you all of the online forms that we're going to use. I think they're fantastic, and I'm really optimistic it's going to be a big step up from last time. The other really great thing about it is it also gives you access to real-time feedback. So unlike waiting for data to come back to you at the end of the first year, and I'm aware last time in the audit, a lot of people didn't really get any trust level performance feedback until well into the second year of the audit, so not really enough time to use it to inform change. The new platform, You can log in anytime and download all your data, and it's very easy. Get it out in an Excel format so you can use it for presentations. But also, there's a dashboard which allows you to look at it and say, how am I doing this week? How many patients this month have missed quality standard 2 or 3? And I'll talk to you a bit about that in a moment. Another thing that's changed is that we're also not collecting only the first 3 months of data. We're collecting data that's going to go out to 12 months. So if you remember in the last national audit, we only collected data at the time point 0 and then at each follow-up visit until the 3-month visit. For this audit, we're collecting data out to 12 months, but we've streamlined quite significantly what data we're capturing. So we're only collecting information at time 0, time 3 months, and time 12 months. And what we're collecting has been significantly curtailed, and I'll show you all of the data we're going to collect. And I've mentioned we've got this best practice tariff link. So the historic best practice tariff was around a whole bundle of care to be delivered for early inflammatory arthritis, and that has changed, and I'll show you what we're hoping to get. So this is what we're hoping to collect data on. First of all, we're going to be looking at adults, so people aged 16 and over presenting for the first time with an early inflammatory arthritis. However, we're going to recruit anyone who has suspected early inflammatory arthritis for the first step of the audit, but we will only collect limited data. Then as we go forward, we will collect more detailed follow-up data on those with an established diagnosis. And people often say, well, for example, if someone presents with joint pains and it turns out they've got OA, do I include those in the audit? So for this audit, anyone referred where inflammatory arthritis was even suspected, irrespective of the final diagnosis, should be included. And the reason for this is it's a little bit like if you think about a lung cancer audit. If someone is going to audit lung cancer services, how quickly do you see people with suspected lung cancer? You can't just audit those people who have lung cancer. You have to audit everyone referred. So that the sort of the 2-week wait model, you have to say anyone referred with a suspected diagnosis, did we see them within 2 weeks? Because you need the information on everyone referred, not just those with the actual diagnosis. However, we realise that in order to calculate performance at quality standard 1 and 2, we only need a very small amount of information. And I'll show you what we're going to do for that. In addition, we're collecting organisational data as we did last time, but again, we've streamlined it. So we really just need to know what sort of service you run, how many consultants, specialist nurses, trainees, non-consultant specialists you have, how many, whether you have EIA clinics, whether you have access to ultrasound, what allied health professional service access do you have. Catchment population and a lot of the other organisational details we are going to collect centrally. So for example, the catchment populations, which is always a bit of a challenge, we're collecting centrally through NHS Digital and CCG data. The audit itself is then going to focus on the same 7 quality statements in the quality standard 33 from NICE. We're going to collect information at time point 0, 3 months and 12 months. For axial spondyloarthritis, we're only collecting baseline data, but we are going to collect waiting time and a little bit of additional information for axial SPA, although this is primarily an early rheumatoid audit. At 3 months and 12 months, the thing that changes is, compared to the last audit, for this audit, we're also going to be collecting data on biologics use, so whether people convert to a biologic, and also the annual review, and I'll show you what we're going to collect for the annual review. Patient-reported measures for this audit is going to include the MSK-HQ. So that's, if people remember the last audit, we collected the RAID, and the MSK-HQ and the RAID are very similar in construct. They're both patient-reported measures of the impact of rheumatoid arthritis, although the MSQ has some advantages in that it's validated across other disease areas. So for the early inflammatory disease, if they've got PSA or rheumatoid, it doesn't matter, it's validated across those. And it also collects information on some additional domains that aren't in the RAID. It takes very similar time to complete. The HAC, I think everyone's very familiar with the HAC, the Health Assessment Questionnaire. We're going to collect measures on work and also mental health. The mental health collection, data collection, is using 2 tools, the PHQ and the GAD, and both of them are 2-item questions. So it is a very simple screener. It's the one that's recommended by NICE for screening for mental health comorbidity. And we're not collecting any patient-reported experience measures. We learned sort of from the last audit that actually it's very difficult to collect PREM data like this. And it also raises challenges that we're collecting data saying, how's your department doing via the department itself. So it's not the best way to collect PREM information. That we'll have to do separately. The IT platform is the really exciting bit, and this is the bit that's new for this audit. We've got a new provider, NetSolving, who have been fantastic to work with. We're going to have two websites. Well, we have two websites. One for clinicians, www.arthritisaudit.org, and one for patients, which is the same, except it's www.myarthritisaudit.org. There's a unique identifier, which is going to be the NHS number, which will link across all the records. And we're going to be much more interactive with you about how we know when follow-up forms are complete. We'll give alerts when 3 months and 12-month forms are due. And we've got this dashboard, which we can continue to evolve as time goes by. And I think one of the challenges we had with the last audit was the IT platform, once it was there, was pretty much a static, unchangeable platform, whereas the links we've got with NetSolving are such that, as particularly things like the dashboard, we can evolve that as time goes by. And you'll be able to download from it. So in a very simple download format, you'll be able to get your data out to say, how are we doing? There'll be benchmark data for national performance, current national performance for you to then compare across, so that you don't wait for a year before you start looking at performance and making changes. And I hope that we're going to be able to really inspire some really great projects looking at EIA care. So this is the website. This is what it looks like. You log in, the front page. You don't have to be through an NHS computer. You can do this at home if that's what you want to do at home. But you will notice there's a timeout function, unfortunately. Well, not unfortunately, it's there for good reason. But because we've got to run this platform across so many different hospitals and so many different information governance sort of rules that come into question, once you've logged in, after 20 minutes, it logs you out. You have to log in again. It's incredibly quick to log in. And also, once you've logged in, sorry, if you log in and you forget your password, in the old system, you remember you had to then email a BSR to get a new password. Now you don't. If you forget your password, you click please send me a new password. It does it instantly back to your NHS mail account or to whichever email you've linked it to. So, and also in terms of getting new users added, we can do that at the hospital level. So we will allocate administrative rights to add new users at the individual hospital level. So you don't keep having to come back to the central IT system to change anything. I'll go through the forms now, but I hope as you look at these, you'll realize that these are pretty much foolproof in the information we're asking. This is the first page, and I've cut off the bottom, but I will show you it. I'm going to show you all the forms, so there's nothing a surprise. So along the top, you've got these tabs: demographics, diagnosis, baseline, 3 and then 12-month follow-up. And each of these will be colored. So once you start to enter data, they go from red to orange. And if they're complete, they'll go to green. And if they're not yet even looked at, they're blue because they've not been looked at and saved at all. And you can see we're collecting the data form entry, patient's name, NHS number, and hospital ID. The hospital ID allows you, if you export the data, you'll then be able to, because a lot of hospitals, I think, find it easier to link by hospital ID. Date of birth, gender, ethnicity, patient's postcode, and also the postcode of their GP. And there's a really important reason why we need the GP's postcode. And that's because when you're looking at the best practice tariff, payments for best practice tariff are aligned to CCG, not by the trust someone's seen in. So in order to be able to work out the CCG that a patient links to, we need their GP's postcode, which is why we need that information. So if we don't get that, we wouldn't be able to align to best practice tariff. And it also allows us to provide on the dashboard CCG level data. Date they're seen in the clinic, were they referred by an EIA pathway? And then same page, and so you see the referred via an EIA pathway now question at the top. Date the letter was written, the date it was received, a question about work, a question about symptom duration prior to referral, and was the referral made within 3 working days with EIA symptoms in accordance with NICE Quality Standard 1? Then this is the really, I think, a really good bit about the new website is we then ask you how the patient would like to be contacted. So this is an audit. We're not asking you to take any written consent. That's not a requirement for audit. You just verbal consent that the patient's aware you're doing this. We will ask you to provide the patient with written information about the audit and details about how they can be excluded from the audit at any time, but they don't need to be consented. We are concurrently applying for Section 251 approval from the Clinical Advisory Group, which is the NHS mandate that will allow us to do the data analysis and linkage without consent. This is not a research project, it's an NHS mandated audit. And I think everyone would agree that to have to take consent, in addition to diagnose someone with rheumatoid, tell them they've got rheumatoid arthritis, tell them they need to start on drugs like methotrexate for the rest of their life, and then to say, by the by, can I consent you to take part in an audit, would be an unfair burden on the patient and be detrimental to our clinic flow. So once the patient, you tell them that they're being involved in the audit, they have the opportunity to withdraw, but then the way we contact them, the primary route I'm hoping is by email. And so all the patient-reported outcome measures, we will email to the patient directly the request for them to log on to their website with the NHS number as their unique identifier to then fill in the forms themselves online at home. And so this takes away the burden, because I think with a well-trained patient, one of our patient volunteers going through the questionnaires, it's probably about 12 or 15 minutes to fill in all the baseline forms, to read them through and fill them in. And that's quite a burden on the clinic. So this allows you to pass the questionnaire filling to the patient in their own home. Now, we know that asking people for email returns of questionnaires isn't going to be 100%. The last audit we had about 30% of our patient-reported outcome measures captured. I think it'll be better than that. Most studies suggest you probably get between 40 and 50% if you do emails. If you get reminders, you can get it up a bit. There are other options as well, though. So you could click telephone and record a patient's telephone number, and then someone in the trust could phone the patient. If you've got a nurse or an audit administrator, you could phone them to do it over the phone. Or you could collect them in real time with the patient with you in clinic, and I'll show you the tabs to do that in a minute. This is then the diagnosis form. So you put the date, the diagnosis at the top, and if you just have a look at this, so say you clicked on OA or fibromyalgia, you would then get this screen that would come up saying, thank you for participating, no further information is required, because we will then have captured sufficient information to know about the speed of referral from primary care and to secondary care. And if the diagnosis is not an inflammatory arthritis, they are no longer need to collect any further information. So that's a very quick data entry. If they had axial spondyloarthritis, we do ask an additional 4 questions. So for people with axial SPA, we also ask them if there's an HLA-B27 result, where they were referred from, if there's plain radiograph or MRI evidence of spondyloarthritis, either yes, no, don't know, or not done. This is, I think, a light touch, but what will be incredibly valuable piece of additional information for our axial spondyloarthritis colleagues. So I'm really pleased this is in the audit, and I don't think it puts undue burden on people in terms of data collection. But for most people, if they who've got rheumatoid arthritis, you'll then click that they've got rheumatoid, date of diagnosis, and then question 2.4 says, is the patient eligible for follow-up? And this is where there is a certain amount of clinician discretion, because if, for example, you referred someone who was previously under the care of another hospital with rheumatoid, they were referred to your hospital via the EIA pathway, but actually they've got established disease, they do not need to go into an early arthritis pathway. In the same way, if you see someone who's got one swollen joint, and so if you think that this person needs following up, I'm going to see them in 12 months, but they do not need to go into an EIA pathway, then this is where you have your clinician discretion. So this person isn't eligible for follow-up with early inflammatory arthritis. If you're ever unsure about any of these questions and you look at the little blue question marks and hover over those are the FAQ tabs, which give additional information on what's in those questions and how to answer. And again, I'm always very happy to help, or the BSR, we've got a help to try and help people in terms of what these questions mean. So if they have rheumatoid, this is the baseline form. And what we've got here is date forms completed, the data you need to complete the disease activity score, the rheumatoid factor CCP results, and then was a disease-modifying therapy commenced. We don't care if it's combination or monotherapy. Remember, if you've seen the new nice draft guidelines for RA, they no longer recommend combination therapy for all. So we're not going to be assessing whether it's combination or just how quickly did we start DMARD therapy. One of the things that's always a bit of a challenge is if you see someone, say I diagnose someone today and I say I'm going to ask them to see my nurse in a week to start DMARD therapy, would I tick them as started today? Well, I think if I didn't issue a prescription, I would say no. But then at the 3-month follow-up, I will say yes, and in the 3-month follow-up, I'll put the date, which will be 1 week from now. So as opposed to, I suppose, if I saw someone today and I gave them a prescription today, I would tick yes, I've given them a DMARD today. Corticosteroids, oral or parenteral. Has disease-specific education material been offered? Was a treatment target of LDAS or remission agreed? Has a helpline information been given? And then also question 3.14 is comorbidity. And you'll see that there are a list of comorbidities, which is by far from complete. The reason for this is one of the things HQIP are very keen we do when we're reporting on this audit in the annual reports is to do some adjustment for case mix. I think we're all too aware that across the country, we all see different types of patients with different levels of comorbidity. And if we don't take that into account, it can unfairly penalise certain providers. So there's quite good models for case mix adjustment in national audit. One of the challenges, of course, is that comorbidity listings are different for different diseases. They have different impacts on different diseases. So what we've done is we've used probably the most validated of the rheumatoid comorbidity indexes called the Rheumatic Diseases Comorbidity Index, or the RDCI, which requires a yes-no answer to the variables listed here. So that's why those variables are in. I'm fully aware that it's a far from perfect index, but I think it's the most validated of the ones out there for us to use. This is a 3-month follow-up form, which you'll see the top sections are identical about the date of form completion, date of assessment, the disease activity score measures, either with ESR or CRP, you don't need both. Then we ask how many appointments the patient has had, either face-to-face or telephone, since their diagnosis, whether they're receiving DMARD therapy and when that DMARD therapy was started. And that's the opportunity. If you didn't put it in on day 1, then this would be your opportunity to say they started methotrexate and the date they started it was perhaps 1 week after their first visit. Allied healthcare professional referral, and then has disease-specific education, including information on self-management, being provided. 12 months, this is the final form from clinicians. And again, it's identical to the 3-month form, except we now ask about the use of any targeted therapies. So not biologics, because we've had a JAK inhibitor to this, but have they started on a targeted therapy, even if it's been discontinued, and which one? And then in addition, at the bottom, annual review. And what we do for annual review is we don't want to know the results of the annual review. We just want to know if it's taken place. And we also are not asking where it's taken place. So when someone comes to that 12-month review, have they had an annual review, primary care or secondary care? And has it included a bone assessment, a cardiovascular assessment, and a measure of disability? And we're not asking for the result, just whether or not it has taken place. The patient data, and so all the way along, you'll have seen across the tabs, you've got the demographics, diagnosis, baseline, and follow-up tabs. Above that, you could also click directly in to enter the patient data at the time points, baseline, 3 months, or 12 months. So if you had a nurse doing the visit, they could log in and do that in real time with the patients. Or if you don't do that and you'd select by email, they'll be emailed from the audit website, from the arthritisaudit.org website, will email the patients directly. And you can also offer to print out copies locally. So you can download from the website the paper copies of all the outcome measures, the patient-reported outcome measures, and print those. And then you'd have to collect those on paper and upload them if you've got an audit team who would then upload onto the website subsequently. We're not going to be accepting any paper forms centrally. The central analysis all relies on electronic data capture. So the dashboards I've mentioned, I think these are going to be really crucial. And I imagine they will evolve quite significantly over the time as we learn what works, what doesn't work. We're going to try and underpin it very much by QIP methodology. So looking at using run charts for information around your recruitment rates, your data completeness, and your performance against the standards with benchmarking. So you'll see a bar chart showing, in January, this many people were seen within 3 weeks and started treatment within 6. February, it was this many, and so forth. And along that, you'll have a sort of a horizontal line. It'll say this is the national current average, and this is what you're aiming for. Some of the questions that have come back, and I'm going to draw to a close just in a second. I'll just touch on best practice tariff, but there's lots of FAQs that we're going to have on the website. There's a whole page about them. Some of the common ones: can the BSR help? Not financially, but they can help with trying to leverage your trust at a higher level, writing to CEOs, and we are communicating with all trusts that the audit is going to be going live again. It's an HQIP audit, so it's not optional. Anything that HQIP commissions, it is within the NHS contract that all NHS providers must take part in HQIP funded audits, and that is included in the costing model for the trust. Of course, it's the NHS, so it's not really included. We're just, expected to do it. But I've mentioned that the audit tool, I think, should be much better than the last one, much more interactive, much more local control with local administrators, and there's lots of people on hand in the BSR as well who can help. I think in terms of collecting data in real time, I think ideally the tool is designed so you can do. Being realistic, I think particularly for the first appointment for a new patient, it's really hard to get everything in the time we have. For a 30-minute new patient appointment, to diagnose rheumatoid is a high ask. So I think for newly diagnosed rheumatoid, it may not be. But for the people who don't have rheumatoid, it probably is feasible to do it in clinic, and which will be hopefully the majority of actual total entries. We know that most people referred to an EIA pathway don't have rheumatoid. And also for the follow-up, if they're in a nurse-led clinic, it may well be feasible. And I've mentioned if a patient doesn't have email, then you can collect it on paper forms, or you can do it with the patient in real time. So that comes on to the final bit, which is the best practice tariff. So the aim of a best practice tariff is to encourage best practice. It's not about earning more money, and there's no new pot of money with BPT. Although I think it is definitely true that the historic best practice tariff did have a challenge, because a lot of people realised that if you see people monthly, then you will get paid more through the standard rheumatology tariff than if you take the best practice tariff. Because what happened with the old BPT is you had a fixed bundle of money that came with people with EIA who were put through that pathway. Now, new BPTs are being developed across the board, so all the best practice tariffs have been reviewed. And one of the things that they've said with best practice tariffs is they want them all to be aligned to national audit. So this is the proposal. The first thing is that in order to receive the best practice tariff, you still get paid all the tariffs you would usually get for standard care. So you can never lose money by taking part. So that if you see someone 5 times or 10 times in the year, and irrespective of how many tests you order, you'll be able to charge for those however you currently charge. And that includes if you're on a block contract or not, that pricing will be the same. However, if you have met these 6 standards, you'll be eligible for an additional uplift payment. So if you see them within 3 weeks of referral, if they are enrolled in the audit, and that's essential because we collect, the CCGs will collect the data directly through the audit. If they commence a DMARD within 6 weeks of referral, if they've had disease education within a month of diagnosis, and if there is a DAS documented by 3 months, and a PRO, so for example, the MSKHQ or HAC documented by 3 months. If you meet all of those checkpoints, then you are eligible for an uplift on your tariff. So you'll be paid the standard care plus an additional bonus amount. This is likely to come live in April 2019. So this wouldn't happen in April this year. This is another 15 months away, and so the current best practice tariff isn't changing yet. But when it does change, this is what it would look like, with the intention that not all patients who you enroll who have rheumatoid will be eligible for this, because you won't. Some people, it's just not possible to start DMARDs within 6 weeks, and the tariff is costed on that assumption that they can't afford to pay it for everyone, but for a proportion, and it's working out exactly what that proportion will be will determine the amount of money it'll be valued at, whether it's 100 or a couple £100. It's not going to be enormous sums. But what is clear is it is going to be something that will be on the CQC radar. So when a CQC looks at your performance as a trust, they will say, how were you doing in the HQIP audit? How many people did you get into the best practice tariff? One of the things we've done about this is all of the data needed to know if you're eligible for an uplift are collected through the audit tool, and the audit will then report back at CCG level for your trust. So it'll say, for your trust, how many patients in all the CCGs that feed into your trust are eligible for a BPT uplift. That report is then available for you to see and to share with your CCGs. So from an administrative point of view, it's very light touch. I think I've overrun by 2 or 3 minutes, but I hope that has been a sort of run through of the new national audit, the National Early Inflammatory Arthritis Audit. And I'm going to stop the recording now, but I'll stay on the line for a few minutes if anyone's got any questions that they can send in on the chat. Thank you very much.